Thank you for the opportunity to present treatment side effects in cancer survivorship. I'm Dr. Jennifer Klemp. I'm a professor of medicine in the Division of Medical Oncology and the Director of Cancer Survivorship at the University of Kansas Cancer Center. Here are my disclosures. And today we're really going to focus on late and long-term effects, how we can manage those, the role that a patient can play in their care, and how do we use these tools across our cancer journey and the cancer control continuum. So I always like to start out with kind of right-sizing what we mean by survivorship, and whether we like the term or we're not comfortable with the term. This term was coined a long time ago, and I know that when we opened our survivorship program in 2006, we did do focus groups to really try to figure out what did folks want to call our program, and ultimately we all kind of land back on the same term, which is survivor, which is from the time of diagnosis through the lifespan or balance of life. And then it also includes caregivers, loved ones, and those who support the individual going through the cancer journey. I know this doesn't always resonate, but it does include patients living with and patients living through their cancer. And so this could be somebody who has ongoing metastatic disease. It could be a patient who's been disease-free for 10 years, but we know that there's always risk for late and long-term effects. And so that's really where the crux of our discussion will occur today. And when we use the word cancer survivor, we do mean anyone diagnosed with cancer through their lifespan. So with the growing cancer population, we know that there are what we call in this diagram the silver tsunami effect. And what that means is that, as you can see in this figure, the 2/3 of the patients living with and through their diagnosis are over 65. And that leads to a patient population that tends to have more comorbid or other types of health conditions, heart disease, diabetes, obesity, things like that. But it also means that we have a lot of patients that we need to think about how do we really co-manage them, maybe with other specialists, with primary care. And when you look at the silver tsunami, the two populations who really have the greatest amount of risk are the youngest and the oldest. So really those at the edges of these curves. And when we think about which types of patients, I'm sorry about that, fall into the silver tsunami, we know that currently breast and prostate are the most common cancers that we see, and they're pretty equal number. However, it does look a little different because prostate cancer survivors are often seen in urology and don't make it into medical oncology until their disease is to a certain stage and a certain level. But as we look at these numbers and we look at our total number of cancer survivors, that's really what I want you to focus on, is that there's a pretty steep increase in a short period of time. So once again, that means patients are living longer with and through their disease. So when we want to anchor survivorship care into a visual, I think that the use of our survivorship map is really helpful. This is the original program development that we put together, as I said, back in 2006, and it's really helped us conceptualize how we want to incorporate survivorship, at what point do we transition patients maybe into a continuity clinic, and how do we really manage those symptoms across the continuum. And what I mean by that is if we go with the definition that cancer survivorship begins at the time of diagnosis, that means we need to be thinking about how we navigate biomarkers and genetic testing. We think about treatment planning, and we really think about that patient journey from the time of diagnosis and into longer-term survivorship. So this journey in between can be pretty complicated. So some patients will never leave a treatment phase of care. Some patients will leave a treatment phase of care, but that roundabout is very purposeful because sometimes they come back to treatment. Some patients will leave and go into sort of extended survivorship and then into long-term or continuity of care. And as we go along this journey, we need to be thinking about how we manage symptoms. And palliative care, I think, sometimes gets sort of intertwined with hospice care, but they're actually different. Palliative care is really for any patient because it helps us palliate or manage patient symptoms. Supportive services, things like occupational therapy, physical therapy, psychosocial oncology, social work, all those supportive care services that really are necessary as we think about managing patients and their complex needs. And then what other types of primary care specialists do we need to incorporate? So this is going to look different, and we're going to explore this a little more in depth. And as patients go along the journey, some of the same exact things we needed to offer to them during the treatment phase are needed in the continuity of care phase. We think about navigation, we think about genetics, we think about cardiotoxicity and our heart health. So really putting this into perspective is important. And I just wanted you guys to be able to see this figure because I think it helps you anchor kind of where you are in your part of the journey, and what this should look like and could look like as you continue down your cancer path. So one of the biggest challenges as we treat patients is we have lots of new types of therapies that we put together. Some have been studied together, some not so long. And they're kind of newer therapies, including IO, which is immunotherapy. So was a patient treated with one or more types of therapy, including surgery, radiation oncology, chemotherapy, immunotherapy? What were those baseline comorbid conditions that a patient walks in the door with or develops as a result of or accelerated by their cancer diagnosis? What are those treatment-related effects? And which clinical challenge really is the greatest risk for the patient sitting in front of us? And this is a really important question because I showed you on an earlier slide that breast and prostate cancer survivors are the largest populations that we have living with and through their disease. But what we also know about early stage older breast and prostate cancer survivors is that they are much more likely to die from cardiovascular disease than their cancer now. So how do we put that into perspective? Do we let patients know this? Are we talking to them about the fact that they received a cardiotoxic therapy and therefore we need to manage them because they already had some risk factors for cardiovascular disease? So how are we communicating your greatest clinical challenge? Are you aware of what those risk factors are and really what you need to be doing about it? So those factors that we just highlighted go into two different buckets. One are called long-term effects. And these are things that would have had an onset during treatment, but can persist past treatment. So maybe that's fatigue. Maybe that is reproductive or fertility issues. Maybe that is sort of cognitive impairment. So what happens today during treatment that persists even post-treatment? And then late effects are those things that may happen 6 months, 12 months, 24 months down the road, or 20 years down the road. Cardiotoxicity, loss of bone density, those types of factors that may impact us. And how do we know that we're at risk? What do we do about that risk? And do our other members of our care team, our primary care or other specialists know about these risks and how to manage those risks? So putting all this into perspective, what I want to show you by this sort of whole person approach is that we really need to be thinking kind of from head to toe. What are we thinking about with psychosocial effects or our cognition, any types of eye issues that could arise, neurologic, pulmonary, meaning our lungs, our heart. So I like to kind of say our brains, our bones, our heart, our lungs, those are kind of some of the main things that are impacted by cancer treatment, but important to put those once again into perspective. So that means we as a cancer care team need to be doing things along the journey. First is we need a baseline understanding of what's happening. So maybe we need to do some baseline tests, or maybe we need to do a risk assessment or a more comprehensive review of systems. We need to educate patients and put that risk into context. Maybe encourage tobacco cessation or encourage a little more movement or nutritional support during treatment. Are we using educational videos? How have we pivoted since COVID? And then we need to do an ongoing risk assessment. So just because we took in a baseline to see what the patient was when they walked in the door, how are we updating that? How are we making sure we keep tabs on that? And then what types of interventions are we offering? So do we offer tobacco cessation? Are we getting you connected with a dietitian? And now since COVID, I think we've had the ability to pivot into a lot of virtual services, but most of our supportive care organizations that we collaborate with do most of their programming now virtually. So I think it's really opened up our support for patients where we don't have to have our patients travel to places. Those are actually available via technology. So the National Comprehensive Cancer Network, or NCCN, has put forth some guidelines on survivorship. And I think this is meant to give a nice comprehensive list of all the things we should be screening, evaluating, and thinking about managing in our cancer survivors. But I will tell you, if we did this entire list that you see here on the screen, that would take a long time. And unfortunately, as you may know from your healthcare experience, healthcare professionals like to get reimbursed for the services that they provide, or we have to have resources to be able to cover those services. And unfortunately, sometimes some of these services are not always covered, and to the extent that we would need to do an assessment and evaluation to the level that would help us manage a patient clinically. So there's sort of this kind of catch-22 that happens, and I think it's really disappointing because these are real issues, and some additional concerns, including fear of recurrence and employment and financial toxicity, really lend to us being able to maintain insurance, to be able to have the care that we need, and thinking about all these potential late and long-term effects. So how do we put this into context? Well, just like we talk about with genetics, and my practice has been cancer genetics for over 20 years. So I like to put everything into risk buckets. And so we want to risk stratify survivorship care too. Not everybody needs the same level of care and support. Not everybody has the same risk factors. So how do we provide risk stratified survivorship care? Well, the first thing we need to do is, once again, we need to sort of have this understanding of putting patients into sort of average risk, high risk, or really high risk buckets. Or maybe for certain things, are they at risk or are they at average risk, right? We could also do 2 buckets, but you could think about how that's helpful, because if someone's at average risk for developing cardiovascular disease, but someone else is at high risk, those are going to be 2 separate pathways in how we manage the patient. And it's really important because, once again, we don't live in a one-size-fits-all healthcare environment, and we don't and shouldn't give every patient the same level of care, because that's not necessary. We need to listen to the patient, look at those complex issues of the patient, and work with the patient to figure out what are their priorities, what are our shared goals, and how do we achieve those goals. So if we have 2 patients sitting in front of us, and maybe we're talking about sort of distress or transportation, but if your daughter is always available to bring you to the cancer center, that checks transportation off your list. So in my situation, maybe I don't have a regular caregiver that can bring me to appointments. I'm going to maybe need some assistance with that. So we have to think about people from those individual needs. Yes, we want to have services available for everyone, but we also need to be able to make sure that we're providing patients with the right level of support that they need. So this goes into, if we think about the 3 buckets, kind of low, moderate, and high risk, we need to stratify that risk or determine what your needs are based on the highest clinical kind of risks, as well as other types of risk, like financial, like psychosocial, you name it. We need to do that needs assessment. We need to assess for the comorbid conditions and engage the patient as well as the care team. So we need some tools to be able to do that. We need someone to help navigate along the journey. We need some sort of instructions or a recipe or a care plan. We need a directory of services of where we can encourage our patients or utilize additional support and resources. How are we going to get people there? So if we know that someone needs to meet with a social worker or a financial counselor, we need to have pathways put in place so that you can achieve the goal of meeting with that person and getting the support that you need, either virtually or in person. We need to educate not just patients, but providers on these late and long-term effects and the resources that are available. And we have to get a whole lot more comfortable with technology. And I think COVID really threw us into that, but we definitely need to continue encouraging the comfort and the tools that are based on technology platforms. We really have to empower both our care teams and our patients and their caregivers to be a lot more comfortable with technology. So this is a really busy slide, and I don't want to distract you with like, what are all these boxes and arrows and circles? The key to this is the cancer treatment journey, right? The diagnosis, the treatment, the follow-up care. And what those little circles are meant to demonstrate is that we need to be doing that risk assessment and evaluation at multiple time points. Maybe a patient comes into us at follow-up care. So we need, oops, I'm sorry about that. So we need to be able to assess them where they enter, but we also need to do that repeated measure. And then here in these boxes, I tried to give you examples of treatment-specific risk, meaning a patient would be considered lower risk based on treatment if maybe they just had surgery alone and didn't have chemotherapy, or maybe they didn't have a lot of toxicity or side effects from their treatment. A person may be at more moderate risk if they had certain types of toxic chemotherapy, if they had radiation, if they had a stem cell transplant, or if they had more toxicity from their therapy. And then patients would be at high risk if they had highly cardiotoxic and toxic chemotherapy, high dose radiation, allogenic stem cell transplants, high risk of recurrence, so a little bit more advanced disease. And really, we think like CAR T and immunotherapy will probably fall somewhere into here. So the important part is that we first stratify based on the treatment. Then we need to layer on those comorbid conditions. Then we need to look at what are those kind of shared goals. So as you can see, the goals to risk assessment mean we need to assess the information, we need to look at the bigger picture, we need to do shared decision-making and figure out our goals, and then we need to kind of keep tabs on it and keep this risk assessment going, not just at one time point, but across the cancer journey. And that means we have to, once again, have kind of multiple levels of engagement. One, we maybe need to use some patient-reported tools where you guys are telling us information about yourself, you're giving us symptom readings, you're communicating. We need to have decent education that really meets the needs of the patient and can be accessed in a variety of different ways for different learning styles. And then we need to have ways to get patients linked up with the right types of interventions so that we can really address and meet those needs. And they're not living with late and long-term effects that frankly have a plan. So I use this term patient-reported outcomes quite a bit. And this is a term that really means the patient reports their own health status on a variety of things, from health-related quality of life, like, are you fatigued? Are you depressed? Are you having, kind of menopausal symptoms? Whatever those are. How is your care? Are you having enough touch points? Are we managing your medications? All those types of things may be asked to you by a survey or what we call patient-reported outcomes. And it requires the patient to engage or the caregiver to engage. But the hard part is that if you don't know the goal of the question and we just throw out 10 questions to you and you're supposed to check the right box or give us a scale of 1 to 5 or 0 to 5, you need context. So the biggest challenge, I think, with using patient-reported outcomes is that we absolutely have to provide the context that goes along with the collection of your information. So I wanted to give you one example. For instance, fatigue, which is very common in cancer patients, both even prior to starting treatment. So some patients report fatigue prior to a diagnosis. We know that patients will experience, and many experience during treatment, and that can persist even after treatment. So we need to know, how severe is it? When did it begin? Do you feel tired most of the time, some of the time, or with specific activities? How long does it last? Does it change? What makes it better or worse? So we need some context. And how should we get this? Do we interview you? Do you fill out a little survey? So this is just an example about how a common issue like fatigue, we need to think about it and kind of break it down into those constructs that go into fatigue. And then how does it affect your everyday life? And part of it is, does it affect your mood and your activity and your interest in engaging in daily activities or hobbies? Is it impacting your relationships with friends or family? Your ability to cope with your treatment? Or does it make you more anxious? How's your job performance? Or are we staying hopeful? And then what do you do about it? We know there are some strategies that can help with fatigue, such as increasing exercise, enriching nutrition. We need to address pain, improve sleep, treat depression, manage anemia, and be aware of those comorbid conditions or medications that could also cause fatigue. So if we do all this at once and we throw everything into the soup pot, then we're not going to know sort of cause and effect. So the other hard part is putting expectations around the management of something like fatigue. So that means that we need to sort of peel back the onion and see, okay, if we help you sleep better, does that improve fatigue so that really it's not as intolerable as it was? If we address depression and really work with cognitive behavioral therapy or maybe some medication management with different types of medications to treat anxiety or depression, does that help? So it's sort of like peeling back that onion shell. So unfortunately, it doesn't happen overnight. And I think providing that expectation that this is something that we need to know about, we need you to tell us sort of the context and a little bit more specific about what that fatigue looks like, feels like, impacts your life. Then we can start determining those strategies that can really help address some of those common symptoms of fatigue. Another similar type of self-reported outcome would deal with fear of recurrence, which is very common and normal. Once again, needs to be reinforced, but most of our patients report triggers in coming to the cancer center, triggers in getting your blood drawn. So we can't ignore the fear. We need a plan. We need to talk about it. We need to focus once again on wellness. Maybe professional help would be a useful tool. And you got to be patient with yourself and know that this is a normal part of the process. So these are types of questions that we may want to ask in a patient-reported outcome, but really are important because they negatively impact our overall quality of life. If we're not dealing with fatigue and we're tired all the time and we can't engage in activities, that really has a trickle-down effect, and we don't engage. And it really causes sort of those dominoes to sort of all fall in a row. So this all leads back into survivorship and what should be in this plan. And lots of professional organizations have given us some guidelines that we need to be looking for things like new or recurrent disease. What about our cancer potentially spreading or a second primary? What about those late and long-term effects that we talked about? What are the interventions and who's helping us coordinate all this stuff with our primary care and other specialists? So if we put this down into more tangible sort of, here's some bullets that we need to focus on. Every time you go in for a survivorship visit, you should have somebody assessing, what's the current status of your disease. They should do a physical exam. Maybe you have some imaging, maybe you don't. Maybe you have some blood work. We also want to look at your functional status. What types of medications are you taking? That includes all natural products, supplements, you name it. What are those comorbid conditions? We need to update that prior cancer treatment and also what's happened to you, because that tells us what late and long-term effects to look for. We always need to look at the personal and family history because maybe update genetic testing would be warranted. We need to look at psychosocial issues, always look at lifestyle, weight control, exercise, and then any disease-specific recommendations, depending on what the primary cancer was, or maybe a genetic mutation that the individual has. So that means it can't be done in a silo. We need to have, your team, and that team needs to be role delineated. Who's doing what on the team? The cancer care team kind of is the quarterback. They're kind of running the show. Your specialists are sort of like your wide receivers, so you need to have them in place. Your primary care, they're kind of like the coach on the side. They're sort of there, not necessarily in every play, but they're really needing to be a big part of your ongoing care. And sometimes, as you know, primary care can kind of be left out to the side and we need to pull them back in. And then the survivor is really the primary person who is the focus of their care. And sometimes that might feel like you're kind of the least equipped to do that. So we have to figure out how to engage survivors so they can be part of this process. And this process can be complicated because maybe you had multimodality treatments where you had multiple types of treatment. Maybe you saw multiple types of people. So how do we put all of these people in perspective to address these issues? And when we think about cancer survivorship, this is actually a new figure off the Office of Cancer Survivorship. And it talks about all of these different pieces where you will need different specialists, different expertise to help kind of coordinate that care and manage that care. But this can be pretty complex. So you do need your team to be able to help put this into perspective. So who does what? So this is some work that we did. And really, I think the interesting part is on the left side, there's some cross-cutting themes. We want to make sure our patients, our providers, our care teams, everybody's talking. But we know that doesn't always happen. So how do we encourage that? We know there's knowledge gaps. There's always updated information. Does our primary care know which guidelines to follow when looking at colon cancer or breast cancer or ovarian cancer? Do they have access to survivorship resources and those supportive care and other specialists that you may need? And what about the organizational structure that you go to? Is there a good plan in place for you to get survivorship care? And if not, do you need to find a place where you can get survivorship care? So these are all important pieces to think about. But your role is important. We need survivor engagement. We need to know that you're participating in your cancer screenings, you're going to your appointments, you're adhering to the medications or the ongoing treatment that you've been recommended. Do you need initial or update genetic testing? So you need to make sure that if we don't ask you, bring it up. It's okay to say, hey, I had testing a long time ago. Is there anything new I should be thinking about? Lifestyle modification, increasing our exercise and improving our diet, smoking cessation or tobacco cessation, and obviously ongoing sun protection. So I wanted to finish with one last topic, which is financial toxicity. And this is interesting because it used to be the initial phases of care were the most expensive. And now we know that because patients are living longer with and through their disease, the survivorship phases of care have become the most expensive. So it leads to a lot of different issues. And I would recommend that you check this resource out because there's increased costs, there's downstream effects of bankruptcy, decreased satisfaction with care, foregoing different medical care because of the cost, poor outcomes based on not getting the care that you need. So we need to make sure that you're linking up with financial counselors or financial resources that are available virtually at the cancer center you go to, the hospital that you seek care at, and make sure that you're bringing these issues up because certain things maybe are a little uncomfortable for us to talk about. And sometimes financial issues can be one of those. But don't hesitate. This is a very important issue and really does impact patient outcomes. So please, engage with your care team, engage with your organization so we can make sure that you're getting your needs met when it comes to financial toxicity. So in summary, there's a whole lot happening in survivorship. It's a moving target, and it's patients for the duration of their lifespan once that diagnosis occurs. Late and long-term effects can occur real time or years down the road. We need a plan in place, and we need to know who's helping us execute that plan. So these are just some food for thought for you to think about as you go through your survivorship journey. And we'd welcome any questions. Please put them in the chat box, and we'll go ahead and get those back to you. And I want to thank you for your time.